Francisco C. Assis, orthopedic surgery. Okay, the objectives of the whole lecture series is to introduce the students to the following concepts. Okay, number one is what is patient safety. Number two, what is a medical error? Number three, what is the culture of safety? Number four, define a comprehensive unit safety program. Number five, measuring quality in surgery. Number six is what are the different never events in surgery, and what is transparency in healthcare. We'd also like to give examples of each concept and to apply the concept to our local setting. Okay. So, as a background, we all have to understand that to err is human. Okay, this is from an essay on criticism by Alexander Pope. We all make mistakes. Okay, in other words, nobody's perfect. Not even your very experienced surgeons is immune to making mistakes. Okay, that's why, okay, in medical care, there are a lot of things that can go wrong. Okay, because there are more procedures, okay, there is a tendency to overtreat your patients. And because there are more procedures, there is more opportunities for things to go wrong. Right? So, what is a medical error? A medical error is number one, an unintended act. Unless, of course, if you really aim to harm this patient, then it becomes a criminal act. Okay, it's not therefore a medical error. So it has to be unintended. It does not achieve its intended outcome. Okay, it could either be an error of execution, okay, mali yung ginawa mo, or an error of planning. Okay, tama yung ginawa mo, pero hindi pala dapat for this patient. Okay, so it could be a deviation from the process of care, because there are nowadays there are accepted standards of care. If you deviate from that, then that might be considered a medical error. Okay, and this is very important for you to remember. It may or may not cause harm. Swerte ka na lang if it does not cause harm. Malas ka lang at malas din ng pasyente if it does cause harm. Okay, a medical error may occur at the individual provider level. Okay, so bawat doktor pwedeng magkamali. Or the system itself, like the whole hospital, may nagkamali. Okay, it may tragically end the life, okay, or accelerate an imminent death. Okay, that is also considered a medical error. Unnecessary medical care has been on the rise. Okay, ever since we came up with different or more procedures. Okay. Unnecessary medical care is defined as unnecessary procedure or diagnostics. Let me give an example. The patient has no cough or cold, okay, but we want to find out, but for one reason or another, we do a chest x-ray. Of course, it's going to be negative, okay, or it's going to be clear. So that may be considered as unnecessary. In fact, 21% of medical care is considered unnecessary. 22% of beds, 25% of tests, and about 11% of procedures may be considered unnecessary. And one of these unnecessary medical care is your overtreatment. For example, for pain meds. Because pain is relative to each person, some would have a tendency to overtreat the pain, lalo na kung kunyari VIP yung iyong pasyente. Siyempre, ayaw mong nasasaktan. Okay? And as an example of that, I hope everybody remembers this guy. Okay, very, very famous, Michael Jackson. Michael Jackson, in June 25, 2009, was administered propofol, okay, to help with his difficulty in sleeping. Michael Jackson had insomnia. On top of that, he had benzodiazepines and lidocaine, all for the treatment of insomnia. Okay, propofol is actually an anesthetic that can like put you to sleep, and if you're not careful, nobody else is breathing for you, you could die, which is actually what happened to Michael Jackson. And because of this, his physician, Dr. Conrad Murray, was convicted of homicide and sentenced to 4 years of prison. Okay, so it could unnecessary medical care could be summarized like this: there's nothing really wrong with you, but I think a little surgery would make us both feel better. Okay. In fact, um, in 2013, medical error was considered number 3, okay, as the most common cause of death in the US, leading to a loss of about $210 billion annually. Okay. And here is another example of a very famous person. This, you might know her as Mary Poppins. This is Julie Andrews. Okay, very, very good singer. Sound of Music. Okay. In 1997, she underwent a routine surgery to remove a laryngeal polyp, but the surgery was botched. Okay, and she was never able to sing professionally again. Of course, the doctor had to pay huge for that. Now, medical error is of different types. Okay, we have here your adverse event, which is an injury caused by medical management rather than the underlying condition of the patient. In other words, you gave a medication, nagbigay ka ng gamot, and nag-allergies yung pasyente. Now that can be considered an adverse event because it's because of your management. Okay? This prolongs hospitalization, produces a disability at discharge, or both, and could be classified as preventable or not unpreventable. Negligence is another type of medical error. It is care that falls below a standard of care, a recognized standard of care. Like, for example, standard of care for pregnancy, for example. You have to deliver a normal baby. Okay? But if something happens and somehow normal lahat pero nag-cerebral palsy yung bata, okay, that could be considered negligence. Okay? Baka kulang yung training yung doctor to do that. Okay. Standard of care is considered to be a care reasonable physician of similar knowledge, training, and experience would use in a similar circumstance. In other words, pwede namang kamayin mo lang yung pag-deliver ng baby, but pa-forceps ka pa. Alright? Some things like that. A near miss, okay, is an error that does not result in patient harm. Okay? But we have to analyze why this near miss happened. Because for this instance, baka near miss lang ito, no harm resulted in the patient. What if pag next time magkaroon na ng harm? Okay, that's why you have to analyze pa rin why this near miss happened. And lastly, or the fourth type of medical error, is the sentinel event, an unexpected occurrence involving death or serious physical or psychological injury. Okay, sentinel event, there is loss of limb or loss of function. Okay, this type of event requires immediate investigation and response. Ito yung pinakagrabe. Okay. Other examples of a sentinel event would be nagbigay ka ng wrong blood type, namatay yung pasyente. Okay. Or wrong side, nag-opera ka pero sa kaliwa pala, hindi sa kanan. Okay. Or you're supposed to apply plate, yung pala nail. Sorry, I'm an orthopedic surgeon. Okay. Those are my examples. And worse is doing a surgery on the wrong patient. This happens if your hospital is may madaming pasyente. Pwede magkaroon ng magkalituhan kasi at ibang pasyente ang maiakyat dun sa OR. Paano kung anesthetized na yung pasyente? Hindi siya makaangal dun sa surgery na gagawin sa kanya na hindi dapat. Okay. Medication error or other treatment-related errors resulting in death is also a sentinel event. And unintentional retention of foreign body in a patient after surgery. Yun, that is also considered a sentinel event. Okay. So, let's now define what patient safety is. Okay. Patient safety is a science that promotes the use of evidence-based medicine and local wisdom to minimize the impact of human error on quality patient care. Because humans are prone to errors, we have to use science and wisdom. Okay, so science and art. Okay, to minimize. We cannot totally eradicate the impact of human error because we are just humans. But these systems are in place so that we can minimize the impact of human error on quality patient care. So, what is the science of patient safety? I have here a picture of a nuclear submarine because the nuclear submarine and medicine, the practice of medicine, are both high-risk systems. That is what they have in common. Pag meron nagkamali sa isang nuclear submarine, okay, pwede kang magkaroon ng nuclear disaster. Okay? Ganun din sa medicine. So, what are high-risk systems? Medicine and the nuclear submarine program are high-risk systems. High-risk systems have the potential to create a catastrophe, an event leading to a loss of human or animal life, despoiling the environment, or situations that give rise to the sense of dread. Sa nuclear program of use, okay, nuclear meltdown. Sa medicine, hindi masyado, pero actually, if you think about it, the situation that we are in right now, like the pandemic, could be considered a catastrophe of na medical ang ano, because had the virus been contained in other countries, okay, it would not have spread like this. So this is actually a catastrophe on a global scale. Okay, that's why medicine is a high-risk system. They are systems that are so complex that they have a large number of highly interdependent subsystems. Ito, sa pandemic pa lang, if you look at it, not just the medical system but also governance and the people itself. Dapat ganun siya kasama, interdependent subsystem siya. Okay? And they are so tightly coupled na like nangyari na ngayon. For example, medyo sorry kung maraming ano dyan, maraming pro-government, but we're thinking maybe they could have done better to prevent the spread of the virus. So government pa lang yon, governance. Paano yung the doctor itself? Paano yung tao din mismo, ng mga pasaway? Okay? Tightly coupled that if one of them does not work in coordination with the others, malaking problema talaga as what is evidenced right now, what is happening right now. Okay? So, now,
wait lang guys I'll change gadgets muna. Just wait for me. Ah, yan, nakikita niyo na?
Yes, Doc. Yes, Doc.
Kita niyo na yan, okay? Sige. So, I'll play it. Yan, kita?
Doc, naka-block lang po.
Naka-block lang. Sige. Wait lang guys.
Work in coordination with the others, malaking problema talaga as what is evidence right now, what is happening right now. Okay? So, now these high risk systems have to be managed by high reliability organizations. Okay? So, high reliability organizations, an example of that would be people who are manning the aircraft carrier flight decks, or people who are manning the air traffic control system, or people in the nuclear power plant. Okay, these high reliability organizations have to have high quality communication under high risk, high stress conditions. Okay, this is because humans who operate and manage complex systems are themselves not sufficiently complex to sense and anticipate problems generated by the system. That's why communication is important. So you are sharing information with each other. That's why, okay, the IATF was formed. First and foremost, it has to be able to communicate between the government, the doctors, and the people so that they can come up with better strategies, okay, for this virus. Okay? And then high reliability organizations have certain common characteristics. Okay? People are supposed to be supportive of one another. Doon natin nakikita minsan nag-aagawan, nag-aaway pa yung mga government officials natin eh. Okay? Hindi dapat yun. People are supposed to be supportive of one another. People trust one another. People have friendly, open relationships emphasizing credibility and attentiveness. And the work environment is resilient and emphasizes creativity and goal achievement, providing strong feelings of credibility and personal trust. In short, people really need to be trusting of one another, which I don't know if you're a political person, your tendency is not to trust. Kaya medyo mahirap i-apply in our situation. Okay? So, we're looking at here of the conceptual model of any organization. Okay? The organization will have to have structure, it will have to have processes, and it would have to have, when you look at the outcome, this is how you measure the quality, okay, of an organization. So the structure, if we apply this to medical practice or medicine, okay, the structure is the physical and organizational tools, equipments, and policies of a hospital, for example. The process would be the application of these tools, equipment, and policies to our patients. And the outcome is if gumaling ba yung pasyente, na walang complications, etc., etc. Those are the results on the patients. That is the Donabidian model. Okay. Now, they are thinking that probably there is a fourth thing that you can measure, which is culture. Okay. What is culture? We want to be able to create a culture of safety in any organization, or specifically in a medical organization. Culture is defined as, culture is to an organization what personality is to an individual. Okay? It is a hidden yet unifying theme that provides meaning, direction, and mobilization. It does not have to be written down. Okay? What we want to inculcate in everyone who is practicing medicine is a culture that shares a constant commitment to safety as a top-level priority that permeates the entire organization. When I say the entire organization, from the medical director all the way down to the janitor who cleans the banyo. They all have to be able to have safety as a top-level priority. Now, the culture of safety, okay, is everyone has to have an acknowledgement of the high risk or error-prone nature of an organization's activities. Okay, if highly infectious yung isang pasyente, tapos medyo laissez-faire, I don't know if you know what it means, medyo pabanjing-banjing yung pag-handle nung samples, for example, pwede mong mahawaan or pwede kayong mahawaan. Okay, so that has to be corrected. Okay, although there has to be an acknowledgement that you are responsible, that you're high risk ang trabaho mo, pero non-punitive yung environment. Okay, pag merong nagkamali, okay, dapat pwedeng, ay sorry sir, nagkamali ako, and then no retaliation, but dapat na-understand ng individual, nagkamali siya, dapat hindi na mangyari yon. Okay? Dapat ganun yung culture of safety. There's an expectation of collaboration across ranks to seek solutions to vulnerabilities, and a willingness on the part of the organization to direct resources to address safety concerns. Okay? Meron ka na ng problema, ito yung solusyon. Kung ayaw naman gawin nung nung organization kasi magastos, baliwala din. Dapat, pag nakita nilang kailangan you have to spend on it, you really have to direct your resources for it. Okay? Now, traditional culture for medicine is a little like this. Okay? Surgeons, supposedly, are less likely to acknowledge their propensity to make mistakes. Okay? They tend to minimize the effect of stress on their ability to make decisions. So, astig daw sila eh. Astig kami. Hindi kami napapagod. Okay? Kaya namin magdesisyon kahit nakakailang OR na kami sa isang araw. Okay? Medyo ganun yung culture ng mga surgeons. In fact, surgical culture is rife with hierarchy, intimidation of other OR personnel, and this prevents the OR staff from pointing out potential errors or mistakes. Okay? Sa medical culture naman, yung mga non-cutting specialties, they strongly value professional autonomy, okay, which promotes individualism over cooperation. So, medical culture, kanya-kanyang kayod, no? Kanya-kanyang ano. So, wala actually communication in between the members of your medical organization, which is also bad. Okay? Now, the safety attitudes questionnaire, okay, is a way to assess the culture in your medical organization. Okay? The safety attitudes questionnaire is a validated survey instrument that can be used for healthcare. Okay? It consists of a series of questions measuring 6 domains. So you look at the teamwork climate, okay? You look at the safety climate, you look at the job satisfaction, okay? Ano yung perception nila of the management? Is management doing well? Or is management good? Are the people in that work area able to recognize stress and the working conditions itself? Okay? And with all the safety attitudes questionnaire that they've been conducting so far in different organizations, they found out that strong teamwork is at the core of any effective organization. Dapat magaling talaga ang teamwork nyo. Okay? And they have a tendency to speak up about safety issues. So pag may napansin, kahit konti, no, sinasabi na kaagad para ma-action na kaagad at hindi nalalaki. Okay? So teamwork and communication, they found out that poor communication contributed to 60% of sentinel events. Okay, 60%. Okay. Traditional surgical hierarchy can prevent OR personnel from sharing important data and expressing safety concerns. Sabihin nila, ano ba naman ako, staff lang naman ako, ikaw yung doktor eh. Pero napansin mo. Okay. Dapat may napansin ka, doctor should be open enough, no, for you to be able to say if there's something wrong. Okay. The standard workflow of the OR itself presents many opportunities for the loss or degradation of clinical information. Lalo na kung maraming papasahan yung mga bagay-bagay. Hand-offs, okay, or the communication between the surgeon and the pathologist. Mga ganun na communication problems. So, since teamwork is very important, how should we be able to measure the teamwork? Okay, the SAQ can be used to measure teamwork and provide a benchmark. The teamwork scores, you see it there, and then communication and collaboration can be rated through the SAQ. Okay. The physicians, ito, from all the SAQs that they did, whenever the physicians or a majority of the physicians rate their teamwork as good, but the nurses on the same team would rate their teamwork as poor. Okay? Bakit ganon? Nurses kasi, pag sinabi mong teamwork, no, nurses describe collaboration as having their inputs respected. So pag may sinabi silang idea, no, napapakinggan. Doctors naman describe good collaboration as having nurses who can anticipate needs and follow instructions. So dun pa lang medyo may communication may communication gap na. Alright? So something like this. Okay, don't correct me, Nurse Kinley. When I said ruptured spleen, I meant ruptured spleen. Okay, so it's clear that sometimes, or a lot of times, there are communication problems. Okay, that's why high reliability organizations must have plenty of opportunities to communicate with the different members. Okay, you have there your prompts, your checks, your SOPs, your team briefings, and debriefings. Okay, so operating room briefings, okay, they help to transfer information between the team members. Any pre-procedure discussion of requirements or needs or special issues must be discussed in the operating room briefings. Okay, improved safety culture, increased wrong side awareness, early reporting of equipment problem, reduced OR cost, and fewer unexpected delays. Okay, these are what you have to be discussing in your pre-operative briefing. Okay. Dapat kasama din yan when you have your pre-operative conference. Okay, pag nag-pre-op conference, before doing surgery, you have to be discussing exactly step by step kung anong gagawin mong plano para doon sa pasyente mo. Okay, that's a way to minimize or improve safety. Okay. Now, operating room debriefings naman, you do this after you do the surgery. Okay, it allows for discussion and reflection on causes for errors kung merong something went wrong, and critical incidents that occurred during OR. Okay. It is considered a learning opportunity rather than cause for punishment. Okay. You always want to discuss what went wrong, but then you should also discuss what went well. Okay. Some things like mislabeling of specimens, okay, can be discussed in your operating room debriefings. Now, sign outs, okay, refers to either a verbal or written communication of patient information that familiarizes incoming doctors of patients. If you do your notes, like your SOAP, okay, you do this so that you can endorse your patient to the next set of doctors that's going to handle them. Okay. Problem with the sign outs is that it could be variable, unstructured, and very prone to error. Okay. It can have content omissions, okay, as part of the communication process. Okay. The way to do the proper sign outs that is more structured is if there are nurses here, or former nurses here, okay, you do your S-bar, right? But for us doctors, we do the SOAP. Okay, you note there your SOAP. That's how you endorse your patients. So next, after communication, okay, you can form what you call your comprehensive unit-based safety program. Okay. As medical care expands, it becomes more fragmented, okay, and this leads to communication problem. So to address this, okay, gagawin mo, you are combining it or breaking it down into different units, okay, and each unit will hold these meetings, so your briefing, debriefing, and sign outs regularly, and involves the hospital management, okay, just to ensure that everything else is communicated. Okay, the CUSP has been associated with improved patient outcomes. Okay. I think I will end my part 1 here. Okay.
Okay, sorry for the technical problems, guys. Yeah. Do you have any questions for the first lecture? Siguro hindi siya ganun ka-medical but it's a lecture that's very important because everybody has to be on board with the culture of safety, especially in the hospital. No? So again, are there any questions?
None, Doc.
Guys, malino naman ano, the concepts, the culture of safety, what a medical error is. Anyway, if you have if you need further clarifications, nahiyaan lang kayo magtanong ngayon. All of this is in Schwartz naman. It's in chapter 12. Okay? So you sure there are no questions?
Yes, Doc. Wala po.
Okay, sige. If there are no questions, we'll now go to the second video.
Good day once again, and welcome to the second part of this lecture on patient safety in surgery. For the second part, we'll now be discussing how we measure quality in surgery. Okay. There are actually a few tools to measure how effective patient safety is. In the US, there are several agencies and private groups that developed criteria to evaluate safety within the hospitals. Now, probably the most commonly used and what's probably familiar with you is called the practice pattern measures or the clinical practice guidelines or the CPGs. Okay, these are a set of guidelines that is doctor defined and specialty specific. It is deemed to be smart and fair, and this is what's actually pushed by the medical societies. Okay. Now, here's an example of how not to follow your clinical practice guidelines. Okay. Right. So, one of the agencies formed to measure safety, patient safety, was the Agency for Healthcare Research and Quality, or the AHRQ. This was formed in 1989 in the US as a sort of public health service agency. Its mission was to improve the quality, safety, and efficiency of surgery and to assess the effectiveness of healthcare for all Americans. About 80% of their budget went mostly to research grants, and this was conducted by the universities. It's an evidence-based information on healthcare outcomes. Right. One of the major contributions of the AHRQ is the patient safety indicators. Okay, you can see here on the right. Okay, these are the patient safety indicators that the AHRQ came up with. It is a tool to help health system leaders identify potential adverse events occurring during hospitalizations. Okay. The PSIs, or patient safety indicators, are not considered are considered indicators and not definitive measures. Okay. Next is the Surgical Care Improvement Project. Okay. This is an organization that's committed to improving surgical care by reducing surgical complications. Okay. It's comprised of various non-government organizations and government entities. The SCIP identified 3 broad areas where potential complications have the highest incidence. These are the surgical site infections, the venous thromboembolism, and the adverse cardiac event. Here in the Philippines, the venous thromboembolism is not so much of a factor, and this is because we're fond of eating spicy food, which is supposed to help thin out our blood, thus preventing venous thromboembolism. Now, the SCIP measures that were taken, they looked at the SSIs, okay, the surgical site infections, and they found out that 14 to 16% of hospital-acquired infections. So there are 14 to 16% of hospital-acquired infections, and this increased the length of stay. Okay, for adverse cardiac events, about 2 to 5% of non-cardiac cases experience adverse cardiac events, but 34% for patients undergoing vascular surgery were found. No, most of the ACEs were found in 34% of patients undergoing vascular surgery, and they suggested that beta blocker therapy be given, which reduces the incidence of this 34% by half. Your deep vein thrombosis, or your DVT, about 25% of all major surgeries were found to have DVT, and it was suggested that prophylaxis by heparin be done to prevent DVT complications. Okay. So this is here on the right, you see the SCIP measures, okay, and these are the different suggestions that they discussed. Now, next entity is the National Surgical Quality Improvement Program. It's a measurement program that allows hospitals to sample their post-operative events and compare them with similar hospitals, sort of like comparing notes. Okay, it uses a risk-adjusted ratio of the observed to the expected outcome. When you say risk-adjusted ratio, depends on the resources of the hospital, because not all hospitals are equal. Okay, if you have a very nice hospital, your risk is lesser, so dapat mas mababa yung mortality and morbidity mo compared to a provincial hospital, for example. Okay, that's the risk-adjusted ratio. Here, the NSQIP, all right, there is involvement of the private sector. Okay, and this has helped shift the focus from just merely preventing errors to the larger goal of preventing all types of adverse post-operative outcomes. Okay, the insights that have arisen from the NSQIP, they determined that safety is indistinguishable from overall quality and should not be addressed separately. In other words, safety means you did a good surgery. Okay, and adverse outcomes are primarily determined by the quality of the systems of care rather than provider incompetence. Okay, so they're saying that the adverse outcomes, not really because of the doctor, or it's not mostly the doctor's fault, but more often than not, it's because of the system. Okay, and then reliable comparative outcomes are imperative for identification of system problems. When you do comparative outcomes, okay, you have to be able to identify which are problematic in your system. Okay, the next group is the Leapfrog group. Okay, this is an alliance of large public and private health purchasers. Okay, and they aim to improve nationwide standards of healthcare quality, optimizing patient outcome, and ultimately lowering the cost. Because if you took care of your patients, lesser complications, okay, lesser cost, right? So they provide patient referral, financial incentives, and public recognition for hospitals that practice evidence-based medicine. They would like to promote, okay, hospitals that are doing well, because when you do well, you're supposed to be taking care of your patients well, and therefore these patients are safe. Okay. They initially espoused the use of computerized physician order entry system so that there's less errors in reading your orders. Okay. They also noted the 24-hour ICU physician staffing, so there's always a doctor on duty at the ICU any time of the day. Okay. And they used evidence-based hospital referral standards for high-risk operations. Okay. They collect data voluntarily, and this is web-based. Later on, I'll show you the website, okay, of the Leapfrog group. And they also suggested that hospital use the hospital and surgeon volume criteria. What this means is that for a certain doctor or a certain type of specialty, you only have a limited number of patients to take care of. This is to prevent burnout. Okay, and this is what I said about the Leapfrog Hospital or the Leapfrog Group. This is their website. You can type in the name of your hospital and find out if your hospital is safe or not. Okay, just to give you a sample. Now, the next organization looking at patient safety, of course, is the World Health Organization. In October 2004, the World Alliance for Patient Safety was formed. Okay. They implemented a series of safety campaigns. Okay. The second one of these campaigns was focused on improving safety of surgical care. They adapted the tagline, "Safe surgery saves lives." Okay. And they came up with a universal, comprehensive, perioperative surgical safety checklist in the OR. In fact, I'll be showing you what it looks like, and we've adapted it here in our very own FEU NRMF. And they defined a set of uniform measures for national and international surveillance of surgical care, sort of like a surgical APGAR score, if you're familiar with the APGAR score. And again, like I said, this is the surgical safety checklist made by the World Health Organization, okay, for patient safety. These are the questions that you have to answer or you have to check before induction of anesthesia, right before cutting, and then right before the patient leaves the operating room. Okay. And here is our version of that. Okay. So this is the surgical safety checklist. Next, after the World Health Organization, is the National Quality Forum. Okay. It is a coalition of healthcare organizers that has worked to develop and implement a national strategy. So basically, they're into setting up strategies or rules, which is on a national level. Okay. And what this National Quality Forum came up with is the so-called serious reportable events, or the NEVER events. These are errors in medical care that are clearly identifiable, preventable, and with very serious consequences to your patient. This indicates a real problem in the safety and credibility of a healthcare facility. So let's give an example. Some hospital who probably specializes in cardiac surgeries, like Heart Center, for example. Okay, if you have like a series of 3 or 4 patients dying in a span of like 2 weeks, that's a serious reportable event. Okay, that's a NEVER event. Something might be wrong with the system itself. Okay, so again, just to give emphasis, what serious reportable events are. They are unambiguous, okay, so they're clearly identifiable and measurable. Usually these events are preventable and they're serious, resulting in death or loss of body part or disability, and more than transient loss of a body function. Okay. It could be any of the following. It could be an adverse event also. Okay. It's indicative of a problem in the healthcare facility's safety system and or important for public credibility or accountability. So these events are not a reasonable medical risk of a patient undergoing surgery and should never happen. Okay. So these are the surgical NEVER events. Okay. If you perform surgery on the wrong body part, if you perform surgery on the wrong patient, if the wrong surgical procedure was performed on a patient, okay, if you leave something inside that patient, okay, after surgery or after another procedure, okay, or if, for example, you classify the patient as ASA class 1 or ASA 1. ASA means American Society of Anesthesiologists. Okay. It means the patient is very, very healthy. It can very well undergo the surgery, but then the patient dies. Okay. that is also a never event. Okay. So, never events in surgery. Okay, the retained surgical items. It is any surgical item found to be inside the patient after the patient has left the OR, thus requiring a second surgery to remove. Okay. Some say it's about 1 in 8,000. Others say it's less, about 1 in 18,000. But it's most likely to be underestimated. Risk of leaving something increases during emergency surgery or if there's an unplanned change in the procedure. So, most common retained surgical item is the surgical sponge. Surgical sponge is the most common. Other items would also include needles and surgical instruments. Sponges are detected on routine post-op x-rays, also found in patients complaining of a mass or an abdominal pain. Patients with sponges in the intracavitary position can develop abscesses, skin erosion, fistula formation, even bowel obstruction, hematuria, depending on where it was left, or development of a new tumor-like lesion. Retained surgical sponges should always be removed, okay, once you've detected it. So here is what a sponge would look like. Yeah, if you leave it. This part here is radio opaque. All sponges, all that are used in the OR will have this radio opaque ribbon and the likes. Okay, this is to identify a retained sponge on X-ray. Right. Again, this is OS or operating sponge 4x4. This is the radio opaque part, and you will see it like this if you have a retention of sponge. So again, risk factors for retained surgical sponges. You have if the surgery was emergency, if you have an unplanned change in the procedure, okay, like for example, you were planning to just clean it up to here, but then you have to clean also the other side, or you have to clean a bit lower, so there's an unplanned change. Okay, usually you retain the sponge. Okay. Patients who are fat or with higher body mass index have also a tendency to retain the sponge. If there are too many surgeons involved in the same operation, okay, if there are a lot of operations performed on the same patient, okay, if, for example, the procedure is so long that you have to change the staff or the nurses, okay, baka makalimutan mag-endorse, okay, meron at merong maiiwan na surgical sponge. Okay? So, other than surgical sponges, you can also have retained surgical needles. Usually, surgical needles are discovered incidentally, as reports are uncommon. Okay, there has not been a report reported. It have not been reported to cause injury in the same way as non-surgical needles, like sewing needles or hypodermic needles, which were reported to cause bowel perforation or enter the blood vessel and migrate. Okay. This is because most of the time the needles are too small to cause any kind of irritation. Okay. There are, however, some reports of a chronic pelvic pain or ocular irritation caused by retained surgical needles, but very, very rare. Okay. Needles smaller than 13 millimeters have not been shown to cause any injury and can be or probably should be left alone. Just to lighten the mood. Okay. So, next, after your needles and your sponges, is your retained surgical items. The actual incidence of retained surgical instruments is not known. Okay. Usually, you have a pain in the surgical site, a mass, and fullness after surgery. Of course, when you get an X-ray, you get a metallic object. Now, in the US, the most commonly retained instrument is the malleable and the fish. Okay. This is a picture of your malleable. All right. And this is an example of the fish. Okay. It's the Glassman viscera retainer. Sometimes they forget to pull it out, okay, and it gets retained. Or this ring here is also sutured inside, okay? So definitely a retained surgical foreign body, okay, for differentials for patients with pain is a clear differential for patients with pain, infection, palpable mass, radiopaque structure, and imaging. Obviously, pag nakita mo siya on X-ray, yun na yun. Okay? And the diagnosis can usually be made using a CT scan, so that you have a more three-dimensional view. Treatment, of course, is removal of the item. However, if on the process of removing that item, you do more harm than good, then might as well not remove it. Okay. Now, how do you prevent the occurrence of retained surgical items? Okay. The ACS, the APRN for the nurses, and the Joint Commission issued some guidelines on how to prevent retention of surgical items. Okay. You can do standard counting procedures. You can perform thorough wound exploration before closure, and the use of X-ray detectable items like the sponges with the radiopaque ribbons. They strongly endorse post-op debriefing. Okay, so you'll be able to think and to find out or to talk to everybody. Oh, may naiwan ba tayo? May naiwan ba tayo? Etc. etc. Getting an X-ray if there's a concern of foreign body retention due to an incomplete count. Once there's an incomplete count, okay, kahit feeling mo nagkamali lang talaga yung nurse, you have to get an X-ray. Okay? Right. So, what is the benefit of performing a surgical count? Well, they're saying that it might be controversial. Okay? The increased risks of retained surgical sponges during emergency was attributed to bypassing the count. If you don't do a count, the risk increases. Okay. In another study, however, the falsely correct count was associated with most incidences of retained surgical items. Like, sabi nung nurse, for example, has assigned to do the count, kompleto na, yung pala may naiwan pang isa. Okay. Performing the count in itself does not prevent this error, and the counting protocol also imposes significant demand on the nursing staff. So, up for debate pa ngayon yung benefit. But for lack of anything else, we are still doing the surgical sponge count. Even when there's an incorrect count, retained items may still occur. This event is a result of poor communication wherein the surgeon will dismiss the incorrect count or fail to obtain radiographs post-op. So, sabihin ng nurse sa kanya, may kulang, doc. Hindi, okay lang yan. Okay? Hindi siya okay. Dapat i-X-ray siya. Okay. And then the development of multiple lines of defense and adhering to OR safety protocols by all members of the surgical team will help reduce these incidents. So you really have to adhere to the OR safety protocols because pag nakitaan ka ng retained sponge, okay, the principle of res ipsa loquitur, okay, the thing speaks for itself. This will make you liable for leaving that there. Okay. Now, for wrong side surgery, any surgical procedure performed in the wrong patient and the wrong body part, or the wrong side of the body, or the wrong level of the correct body part. This, for orthopedic surgeons like us, this happens more often in spine surgeries where you have to have proper leveling because you know on X-ray that it's L4 or L5, okay, or L1, L2, but when you open, they would all look the same. All right, so minsan talaga nagkakaroon ng wrong side surgery for spine surgeries. Okay. It is difficult to determine the true incidence of wrong side surgery. Okay, there is no standard definition among various healthcare organizations, and apparently wrong side surgery is underreported. The total number of potential opportunities is unknown. Some studies would say 1 in 100,000. Some would say 1 in 15,000. Okay. Now, the risk for performing wrong side surgery increases when there are multiple surgeons involved in the same operation. Yeah, too many cooks spoils the broth. Or multiple procedures are performed on the same patient. Okay. Now, time pressure, emergency surgery, or abnormal patient anatomy, like for example, you are the second one to do the surgery, so puro scar tissue na yun nandoon, medyo mahirap medyo mahirap i-assess intraoperatively. And of course, obesity. The bigger the fat pad, the harder it is to visualize the structures. Okay. Right? Now, communication error apparently is the root cause in more than 70% of wrong side surgeries reported by the Joint Commission. Okay? Minsan, usually in hospitals where there are high volume of surgeries. Okay. So other risk factors for wrong side surgery include incomplete preoperative assessment, okay, inadequate procedures in place to verify the correct surgical site, and an organizational culture that reveres the surgeon as someone whose judgment should never be questioned. Okay, like ang dapat operahan is the left hip. Okay, medyo nahihilo pa yung doktor, siguro post-duty or something, right hip yung binubuksan niya. Dapat hindi magsabi na dapat yung nurse eh. Pero kung revered ang surgeon as someone whose judgment should never be questioned, no, tatahimik na lang yung nurse, which is not good. Okay? So there is a 4-in-1 chance of wrong side surgery for surgeons working on symmetric anatomic structures. Orthopedics, yan, and podiatry, about 41%. Okay. General surgery, 20%, neurosurgery, 14%, urology, 11%, and others. Okay. Mostly involving the lower extremity, about 30%. That's why it's always nice, or it's always good to ask. Just don't ask it while your patient is awake. Baka isipin ng pasyente kung ano-anong ginagawa mo. Okay? So, the Joint Commission made the Universal Protocol to ensure correct surgery. So this one was in the mid-1990s. The Canadian Orthopedic Association and the American Academy of Orthopedic Surgeons formed something so that in 2004, the Joint Commission adopted a universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. There has to be a preoperative timeout or a pause for a cause to confirm the patient, to confirm what procedure you're doing, and what site is to be operated on. Okay, so right before, if you observe in the OR, I hope you get the chance to observe, okay, even with the pandemic, okay, you will note this. The nurse will say time out, and then it will say everyone is present and the name of the patient, etc., etc. This is because of the Joint Commission. Okay. Now, elements of this protocol include the following: verify the patient identity, marking the surgical site, okay, using a preoperative site verification process or a checklist, and confirming the availability of appropriate documents and studies before start of the procedure. For me personally, I need the x-rays of the patient right there at the OR, even before I start doing the surgery. Okay. Timeout immediately before the skin incision. Okay. And all members would actively communicate and provide oral verification of the patient's identity, the site, the procedure, the medications, imaging, and equipment. Monitoring compliance, okay, with the protocol recommendations is also a part of this universal protocol. So, site verification, you have to verify that part that you're going to do the surgery, starts with the initial patient encounter by the surgeon. Pagpasok pa lang ng pasyente, na-assess mo pa lang siya, dapat ma-verify mo na which part is masakit. Okay. So from that initial encounter, it continues throughout the preoperative verification process and during multiple critical points in the OR. Okay. This requires the active participation of the entire team, especially the surgeon and the anesthesiologist. Dapat pag-start pa lang all the way to the finish, pare-pareho yung iniisip nyo na part. Okay. Effectiveness of the wrong side protocol is difficult to measure and it is too rare. Okay. But the number of sentinel events has not changed due to more reporting. In other words, even with this protocol in place, they are saying na hindi naman nagbago yung number of sentinel events. Marami pa rin nag-wrong side protocol. But they're saying naman na baka mas marami lang na-report. Okay? So, yun na yun. Okay, so for the Joint Commission Universal Protocol, the best practices for operating room safety: conduct the protocol, okay, perform an operating room briefing, okay, promote the culture of speaking up for safety concerns, use an X-ray to detect foreign bodies at high-risk cases, okay, and begin patient sign-outs with the most likely immediate safety hazard. Okay. For me personally, I usually do post-operative X-rays, okay, while the patient is on the way from the OR to his or her room. So, with all this in place, okay, still with all these protocols and everything, much of the data about patient safety is not available to the public or to other hospitals. Okay. This allows some hospital to continue to practice outdated medicine or systems and puts patient in a higher risk of serious complications. Okay? Kasi pwede nilang maitago eh. So tuloy-tuloy pa rin sila. Walang repercussions kung madami silang morbidities, etc. etc. Higher mortality in poorly performing hospital range from poor communication between care teams to one rogue surgeon operating when the surgeon should not have been. So they looked at the hospitals who have higher mortality and they found out na mayroong poor communication or mayroong isang doktor na dapat hindi siya nagdodoktor. Okay? Now, making this data transparent, okay, was a decision making data transparent multidisciplinary CASP-like meetings where they decide as a team measures to implement for improvement. In other words, there's a missing line there. You have to make this data transparent, okay? Especially when you are in your CASP-like meetings, okay? This is so you can look at measures to implement for the improvement of your patient safety. Kasi anong basis mo? Ibe-base mo doon sa data na nag-gather mo. If you make it transparent, a lot of other people can look at that data and probably avoid the same mistakes that you were doing. Okay. So, what the SCIP, remember the SCIP? What it's doing is it publishes the practitioner performance. So, ano yung track record mo? Pinapublish nila. Okay. Yung Leapfrog group, the survey results are published online so that other hospitals and the public can see them. Medical societies are rewarding practitioners and hospitals who are transparent with their outcomes. And making hospital outcomes transparent makes hospitals accountable to the public for their outcomes. Okay. Now, public reporting and patient assessment of care. Okay. So in the spirit of transparency, a variety of initiatives was developed focused on the generation and endorsement and reporting of numerous measures related to safety and quality. However, this data gathering of the site was medyo mabagal kasi you have to follow the research process. Okay? Yung iba naman, instead of doing all of this research, they would just publicize it. Okay? And then this has because of social media, has rapidly gained momentum, and it has outpaced the reporting from the measurement science community. So yung mga nire-report lang ng mga na pinapublicize, mas masyado madami na compared dun sa talagang scientifically looking at the data. This would create confusion and uncertainty in the market. Ito naman yung medyo drawback of your transparency. Okay? So, the hospital consumer assessment of healthcare providers and systems, okay? This naman, so before we were looking at hospitals, we were looking at governments, okay? This HCAHPS, okay, is sort of looking at feedback coming from the patients themselves, okay? This initiative is funded and overseen by the AHRQ, and they want to provide a standardized survey instrument and data collection methodology for measuring patients' perspective on hospital care. So ito naman yung point of view ng mga pasyente. Okay, the HCAHPS has 3 goals. First, produce comparable data in the patient's perspective and care that allows objective and meaningful comparison between hospitals on domains that are important to the consumers. Okay? Kasi pasyente ang involved. Okay? So, second, they have to do public reporting of the survey results as designed to create incentives for hospitals to improve quality of care. Siyempre, mababalita ka kung pangit yung survey results mo. Okay? And thirdly, public reporting will serve to enhance public accountability in healthcare by increasing the transparency of the quality vis-a-vis investment. Okay? So of course, kung mas mabango yung hospital mo, mas marami kang investors. Now, what about risk management? Okay. Between 1/2 to 2/3 of hospital-wide adverse events are attributable to surgical care. Okay, so majority of adverse events in the hospital is because of surgery. Most are technical in nature. And previously, before, they were saying that it's because of lack of surgeon specialization, or there's low hospital volume, or communication breakdown, or fatigue, okay, or surgical residents and trainees. However, recently they found out that poor surgical outcomes are not necessarily correlated with the surgeon's level of experience. Okay? Meron at meron talagang complication na nangyayari. So in one study, 75% of the technical errors that occur involved fully trained and experienced surgeons operating within their area of expertise, and 84% occurred in a routine operation that did not require advanced training. Kung ano pa yung madaling procedure, dun pa nagkakamali yung mga experienced surgeons. Okay. These errors likely occurred due to situations complicated by patient comorbidity, complex anatomy, and repeat surgery or equipment problems. Hindi actually yung galing ng surgeon. Baka mayroong external factors. Technical error is not a guarantee that a surgeon is sued. Recent studies point to importance of surgeons' communication skills in averting malpractice litigation. Dito sa Pilipinas, di ba naman masyado uso yung malpractice litigation. Okay? I think that was tried to be corrected before, but it didn't gain momentum. So, what is the importance of communication in managing risk? When we say managing risk, how do you avoid getting sued? Okay? Walang demandahan. The manner and tone in which a physician communicates is potentially more important to avoiding a malpractice claim than the actual content of the dialogue. Relating negatively versus relating positively. Okay? Voice tone is deep, loud, moderately fast, unaccented, and clearly articulated, may communicate a lack of empathy. Parang robot ka na. Okay? And understanding. Okay? Concern or anxiety in a surgeon's voice is often related to expressing concern and empathy. Now, I wrote there general and orthopedic surgeons because supposedly general and orthopedic surgeons, sila yung merong voice tone that is deep, loud, moderately fast, unaccented. Okay? Right, just to lighten the mood. So, when significant errors do occur, okay, if you made a mistake, as we all do, physicians have an ethical and professional responsibility to immediately disclose them to patients. Okay. Failure to disclose errors to patients undermines public confidence in medicine and can create legal liability related to fraud. Okay. If kung di mo inamin, ikaw naman talaga may kasalanan, that is fraud. Okay. Doctors' fear of litigation represents a major barrier to reporting or disclosing. However, they find out that immediate disclosure leads to better rapport. And rapport is the most important factor for prevention of malpractice suits. Okay. Let me just end with this. This is a 27-year-old female who underwent cesarean section. You can see here the scar. Okay. 1.5 years ago. A few weeks, patient noted a purulent discharge coming from this wound here on the left. And you can see this thing that's speaking out. They, of course, went in and removed this, which happens to be an operating sponge. This operating sponge was left there during the first CS. Okay. So this is an example of a retained foreign object. In this case, the most common, an operating sponge. Okay, there's the sponge. So what we do? Of course, once we find out there is, we have to remove that. And I hope we all learned something from this lecture series. Thank you very much.
Okay, so that was the second lecture. Are you still with me, guys?
Yes, Doc. Yes, po, Doc.
Do you have questions about the lecture before I make the questions? Lapit na yung exam niya, di ba? It's like next week. No questions? So, malinaw lahat? Have you had any experience? Of course, everybody has those. Everybody has those. If you don't have those problems or ganun na hindi ka nag-opera, yun ang sasabihin nila sa iyo. Okay, we're only human. Okay. Most naman would be what they call this, near miss. No, thankfully near miss. But I do have those bullseye. And what you do is you just have to relate to your patient that this is what happened. And they actually appreciate it that you're forthcoming with them. You know, you're honest with them. Okay. Was that for everybody? It's a direct message, sorry. Question kasi ni Dominic was, if I have that, any experience of committing any of the mistakes? Yes, technical or otherwise, yes. And that was my answer. Any other question? Dominic, did that answer your question? Okay. Another question here. Adverse effect and allergy. I don't get the question, Christy. Oh, okay. How is allergy po an injury caused by medical management? For one thing, if you are going to do an intervention. You're going to do an intervention. Diba? Ang sabi natin, ang basic tenet in medicine is first do no harm. So you're going to do an intervention. But you did not ask if the patient was allergic to this medication, for example, or to this procedure. Okay? That comes out as negligence. Kasi patient knows. Maliban na lang kung hindi rin alam ng pasyente. Hindi niya alam na allergic siya, nagbigay ka, nagka-allergy siya. But if patient already knows and you forgot to ask or you did not ask, okay, and then nagka-allergy nga siya, yari ka. Kasi dapat tinanong mo si pasyente. Okay? So the question of Christy was, how is allergy po an injury caused by medical management? And that's my answer. So it now, I think you had, if you remember, an SGD on complication versus negligence. Okay, complication versus negligence. Complication happens if you've done everything according to the clinical treatment guidelines, but still something adverse happens, then it's a complication. Okay, but if nagkulang ka doon sa supposed clinical practice guidelines, okay, meron kang hindi nagawa and then nagka-problema yung pasyente, then it might come out as negligence. Kasi yung standard of treatment for this particular case is ganito. And then kung meron kang hindi sinunod, abe, yun na yung problema. Okay, you can be caught negligent for that. Okay, sige. Okay, any other questions? Does that answer your question, Christy? Christy ba? Christine. Christine, okay. Right, anything else? Oh, let me see. Right. Any other question? Who here watches who here watches Netflix? Please raise your hand. Isa lang. Anak na. Okay. Napanood niyo na ba yung The Good Nurse? Napanood niyo yung The Good Nurse?
No, Doc.
Trailer pa lang. Okay. Doon, should I give spoilers? O after finals na? Doon kasi in play kasi yung yung dinag-discuss natin na transparency in medicine. That's why okay yung nila sa states eh. If there are, kasi patients were dying, na siya na nako-compare siya with other hospitals. Okay, and then nagkakaroon ng trend. Okay, because they report it. Now, the rest of the story, you have to watch The Good Nurse to understand it. Okay? Basta in one of those reviews that they did, nagkaroon sila ng mga discoveries, etc., etc. Okay? So, anything else? For those who watched it, naintindihan na yung sinasabi ko. Okay. All right. Anything else? Any questions? No more na? Okay, the question here is, again, the question is directed to me. Doc, okay, dun sa example na binigay ko, kung yung pasyente pa rin ba ang sasagot ng operation fee? Okay, left behind by those surgeons. Sige. The answer is, depende sa usapan. Kaya nga communication is important. Mag-uusap kayo ng pasyente mo. And you come up with a compromise or an arrangement, no? Like, okay lang sa pasyente, naintindihan ng pasyente na things like that happen. Kung may HMO naman siya, HMO na sasagot. Things like that. Kung papayag yung HMO. Okay? Again, depende sa usapan. Most of the time, if you feel na you're responsible, you would also pitch in, di ba? Kasi kawawa naman yung pasyente. But again, it's depende sa usapan. Important thing is, what's the most important thing again for important thing pa rin is rapport. You should have very good rapport with all of your patients. Okay? So, any other question?